All right, everyone. Well, I just want to, my name is Andy Burstein. I'm with Accessible Pharmacy Services for the Blind. I really want to just welcome everyone. Thank you for taking time out of your day to join us, for registering, for participating in this event. For those of you who are not familiar with us, we are Accessible Pharmacy Services for the Blind. We are a home delivery pharmacy and healthcare company focusing on patients who are blind, deafblind, and have low vision. We're the only provider of its kind, and we're the largest blind-owned healthcare company in the country. Everything that we do is designed to make healthcare, at least the parts that we touch, more accessible. And this webinar is actually part of that. A little background about this webinar. About 7 years ago, my wife Sharon was diagnosed with breast cancer. And thankfully, she is fine right now. One of our speakers, Dr. Kim Kubek, is the physician who actually read Sharon's mammogram and essentially saved her life, identified her cancer very early on in its growth. And we are eternally grateful for that. And we're excited that Kim is joining us today. Kim is the thought process as well as like this journey of breast cancer can be more accessible. And we're grateful that she's able to join us today and help us with that. We have a dynamic collection of speakers and guests today. And I'm very excited and grateful for everyone there to join us as well. We have about an hour and a half to speak. We're trying to squeeze a lot of information into that hour. So I just want to say again, thank you for everyone. We're literally just scratching the surface when it comes to merging accessibility in healthcare. So thank you for joining us, but bigger picture, thank you everyone for supporting our company and guiding us and helping us grow. So I'm going to stop talking. I'm going to pass the virtual microphone over to my colleague, Alexandra Luzier. And Alexandra is going to help facilitate the program today, introduce our speakers, and keep the flow of everything going. So thank you again, and I hope you enjoy the program.
Awesome. Thank you, Andy. Sorry, I was spotlighting myself. Thank you again, Andy. My name is Alexandra. I am the Senior Director of Business Development and Communications with Accessible Pharmacy Services for the Blind. And I am thrilled to have the opportunity to put together this webinar for all of you and with all of these presenters. Throughout the webinar, Mel and Emma will be here to supply us with ASL interpretation. So I just want to thank them in advance. And this webinar will also have closed captioning. After the webinar is over, in the next few days, we will be sending out a follow-up email. That follow-up email will have the recordings of the webinar. It will have resources from the webinar and some resources from our presenters, as well as a chance for you to respond with feedback, which we would love for you to do. And this webinar was also certified by the CRCC. That's the Commission on Rehabilitation Counselors. So if you are a healthcare professional that is able to get certified education credit for attending this webinar through the CRCC, please email us after or respond to that follow-up email and we can get that handled for you. Now, I would love to get started and I will now pass the virtual microphone on by bringing in an amazing individual to get us started and to start this show, Sassy Atwater-Wright. And Sassy is the Executive Director of the Massachusetts Association for the Blind and Visually Impaired. And she will be introducing our first presenter. So Sassy, please take it away.
Thank you. Good morning, everybody on the West Coast, and good afternoon to everybody on the East Coast and everyone in between. I'm so grateful to have the opportunity to be here with you this morning. I, as was said, am the Executive Director of the Massachusetts Association for the Blind and Visually Impaired, or MABV as we shorten it, which was co-founded by Helen Keller and a group of her cohorts who wanted to redefine how people with disabilities were able to self-determine their own access to their lives in ways that worked for them, that weren't controlled by bigger systems and complexes. And I want to start with a quote by one of my towering figures that I look up to. I myself am a 5-time cancer survivor. I am not a breast cancer survivor, but I have been with many friends who have dealt with breast cancer. I support many patients going through it as a clinical care chaplain myself, and I have lost family members to it and have seen family members through it. And this quote struck me particularly deeply. Maya says, the love of the family and the love of an individual person can heal, and can heal the scars inflicted by a big and powerful society. That's why we're here today. There's chemo, there's radiation, there's surgery, but then there is love, there is laughter, there is community care. And I would argue that those things are the most powerful medicines we have, especially as disabled individuals facing cancer. Those are the most powerful things that are going to get us through the process of dealing with cancer. And to see a service like this, to see a webinar like this, and to have hope that there will be many more where we can engage with the process of cancer care in different ways was extraordinary and brilliant to me. This was something I instantly had a yes for. I have centered my work on accessibility for people of marginalized genders facing healthcare difficulties and access barriers, oftentimes with multiple disabilities, whether brought on by age or other things that our systems and institutions weren't built to handle. And in 2008, when I got my second diagnosis of cancer, and it was brain tumors, my oncologist said the wisest thing I've ever heard about cancer care to me. She said, now that you're going into this, find the captain of your team who you trust to speak for you when you need a medical professional to help you, who understands disability, who will let you lead them in terms of understanding disability, and who will let you be a leader in your own medical team because you know your body better than anyone else. I've held tight to that wisdom, and to see it lived and demonstrated in today's webinar is extraordinary, and we need more of this. We need a lot more of this, and we need the medical community to stand up and answer it and invite us in as leaders of our own body and our own experience. And that's happening and starting today, especially around breast cancer. We need it more than ever. With that, I'm going to introduce an oncologist who has an extraordinary track record. Kim Kubek started her career at the Hospital of the University of Pennsylvania, and she is a board certified diagnostic radiologist. Dr. Kubek, if I am butchering any of these complicated words, please forgive me. It is 9 a.m. on a Friday. She runs her own diagnostic breast imaging center in Pennsylvania, which is an FDA certified center, mammography facility, in radiology. She is a member of the Society of Breast Imaging in Pennsylvania, and she's a member of the Pennsylvania Radiologic Society. She is on the board of breastcancer.org, and she has been elected as a top doctor of 2020 and 2021 by her peers. I am proud and grateful to introduce Dr. Kim Kubek.
Good afternoon. Can you all hear me?
Yes.
All right. So again, my name is Dr. Kimberly Kubek. I am a wife, a mother of 3, and a physician who has dedicated her professional life to breast imaging. So exactly what does that mean? I went to medical school, completed a 4-year residency in radiology, and then completed a year fellowship in women's imaging, which was primarily breast imaging. In simple terms, I was trained to identify abnormalities on a mammogram. As has been already said, I spent 5 years on staff at Penn before opening up my own private practice dedicated to breast imaging. For the past 30 years, I have read approximately 6,000 mammograms a year, or approximately 180,000 studies in my life. In addition, I also do ultrasounds in my office on all of the patients when needed. So thank you all for spending the next 30 to 40 minutes with me. As you will see, diagnosing breast cancer is my full-time profession. It is my understanding that we will not have time for questions, but my contact information is available to each and every one of you. Call me or email me. My staff and I will answer all phone calls and emails the day we receive them. So let's begin. What is breast cancer? How prevalent is it? And who is at risk? Breast cancer is a malignant disease of the breast. Though it is much more common in women, it does occur in men. In this country, we diagnose 260,000 women every year. We also, unfortunately, lose 41 to 42,000 women every year. So what are your odds? If you take all women into account, 1 in 8 will develop this disease. That is a lifetime risk of 12%. So simply put, between birth and death, every woman has a 12% chance of developing breast cancer. The causes of breast cancer remain obscure. Physicians have no way of predicting who will develop breast cancer and who will be spared. So if you remember only one thing from my talk, it is this: no one is immune. You need to be proactive and vigilant when it comes to your breast health. There are several factors that we feel are associated with breast cancer. The most important factors are being female, getting older, having a family history of breast cancer, having a history of chest radiation, and testing positive for the breast cancer gene. The breast cancer gene, known as BRCA1 and BRCA2, or as we refer to it, BRCA1 and BRCA2, is an inherited mutation. That puts you at an increased risk for both breast and ovarian cancer. You can inherit this mutation from your mother or your father. Most women, however, with breast cancer do not have this mutation. And the American Cancer Society has indicated that approximately 75% of breast cancer occurs in women with no known risk factors other than being female. So let me repeat that because this is so important to remember. 3/4 of women that we diagnose have no known risk factors other than being female. Until methods of prevention are discovered, screening for early detection must be available to all women in our country and around the world. What are the signs of breast cancer? There are many warning signs of breast malignancy, though these signs can also be seen with benign disease. The following list are the most important symptoms that need medical consultation. Number 1, the most important, a breast lump or a lump in the armpit. So what are we talking about here? I'm talking about a lump in your breast that feels slightly firm, maybe irregular, and is usually not painful. What is a lump in your armpit? Well, that could signify enlarged lymph nodes. Number 2, a nipple discharge that is pink, grossly bloody, or black. A milky or clear discharge is usually of no concern. So going back to the pink, grossly bloody, or black, those 3 discharges indicate that there is either fresh blood or old blood in the discharge. Number 3, retraction of the nipple. That means that the nipple is pulled in below the skin surface. Number 4, skin dimpling. You feel your breasts, and if you feel an area that feels a little bit indented or irregular or concave, that is a worrisome sign. Number 5, thickening or scaliness of the skin of the breast. The breast skin should be smooth and not irregular and not scaly. So if you feel some area that feels a little bit roughened, again, you need to contact your clinician. And number 6, and this is also important, and I really want to stress this. Oftentimes, a mastitis, which is an infection in the breast, is confused with a form of breast cancer. So if you have a fever, and if your clinician believes that you have an infection, also called mastitis, you will be put on a 7 to 10 day course of antibiotics. After the course of antibiotics is complete, if your symptoms do not resolve completely, you need to contact a breast specialist. The list above will give you warning signs, but often there are no clinical signs. Hence, as you will learn in the next 20 to 30 minutes, annual screening mammograms, as well as monthly breast self-exams, are crucial to your breast health. What exactly is a breast self-exam? Many women fail to perform breast self-exams because they simply don't know what's normal. They don't know how their breasts should feel. Normal breasts can be lumpy, they can be firm, especially at different times in your menstrual cycle. One breast can be larger than the other, but the more familiar you are with your breasts, the easier it will be for you to detect a clinical change. Breast self-exams can be performed either lying down or standing up in the shower. I think examining your breast while soapy in the shower is the easiest method. So stand upright and examine each breast with the opposite hand. So for example, when you're examining your left breast, I want you to raise your upper left extremity and examine your left breast with your right hand. And when you're examining your right breast, you need to stand in the shower again, raise your right upper extremity, and examine your right breast with your left hand. Use the pads of your fingers, not the tips. Go back and forth from one breast to the other if you think you feel something that feels different from the other side. I instruct all of my patients to start in the armpit and work with your finger pads down towards your nipple. You kind of have to follow the spokes of a wheel, of a bicycle wheel. So you start at the, say at the armpit, you go down towards the nipple, and you slowly follow the spokes of a bicycle wheel until you've examined all quadrants of the breast. You want to try and determine in one breast if you feel something abnormal. And if you are confused, again, go to the opposite breast and see if it feels the same or different in that same area. I have some useful tips that will hopefully encourage you to keep trying breast self-exams. Your breasts are different at different times in your cycle. I find it easiest to examine the breast immediately following your menstrual cycle. If something feels different, again, immediately examine that same spot in the other breast. If it feels the same in the other breast, it most likely represents normal tissue. The breasts are fullest in the upper outer quadrant, that is the area between your armpit and your nipple. So rest assured that this area may feel firmer than the other areas. When you are examining your breasts, press firmly with your finger pads. If you feel a discrete lump, an area that is firm and tender, or an area that feels indented, you need to contact your clinician. Your doctor or other healthcare professional and you are partners in defending you against breast cancer. Your part is to learn breast self-exam techniques and to use them thoroughly and diligently each month. Though I do not encourage you to panic every month, I also beg you to not be complacent. Ask a significant other to, quote unquote, feel what you feel if you are worried. Ask for help. What can we do as physicians to help you? What are our tools? We have made great strides in detection, diagnosis, and treatment, but unfortunately there has been much less progress in prevention. There are no effective vaccines. For the foreseeable future, early detection is our best tool. Here lies your responsibility. Annual mammograms are crucial. Pick a month that you will routinely schedule a mammogram. Many women pick their birthday month. So for example, my birthday is in January. So every January, I schedule my mammogram. What is a mammogram? A mammogram is a low-level X-ray of the breast. It can detect lesions in breast tissue which otherwise go unnoticed because they are too small to feel either during a breast self-exam or during a checkup by your clinician. I and the American College of Radiology recommend a baseline mammogram by the age of 40. There have been varied recommendations for women between the ages of 40 and 70. Some recommend every other year. As a radiologist specializing in breast disease, I obviously recommend yearly mammograms. These recommendations, of course, are for asymptomatic women. If you have any of the findings or the symptoms that I have previously outlined, you need to consult your clinician ASAP and schedule a mammogram immediately. Mammography can be performed with the patient seated or standing. Each breast is imaged in 2 views while the breast is compressed. Breast compression is uncomfortable, but it is necessary because it improves the accuracy of the study by spreading out overlapping tissue. This discomfort is temporary, and compression does not harm the breast tissue. To say that again, it does not harm the breast tissue. In my office, there are 2 technicians in the room with every patient. Usually, one technician operates the machine while the second technician helps position the patient. We are able to image physically and visually impaired patients because of the support of the second technician. The actual exam, which requires 2 views of each breast, takes approximately 10 minutes. You need to undress from the waist up. You will be given a sterile gown that wraps around you but opens in the front. The technician will position you in front of the X-ray unit. You will be asked to elevate your upper extremity as she positions your breast on the compression plate. In other words, when your right breast is being imaged, you will raise your right upper extremity, and the technician will help you position your arm. And when we are imaging the left breast, again, you will raise your left upper extremity with the help of the technician. The technician may have to alter your position several times to ensure that all the breast tissue from the skin to the pectoral muscle is visualized. After the images are taken, you will be escorted to a small waiting room while the images are being reviewed. If there is a radiologist on site, you may get the results immediately. However, in most hospitals and imaging centers, the radiologist is not available. In this case, the results will be mailed to you. The radiologist may request additional views if he or she sees something worrisome or new when compared to the previous study. Please be patient and allow the radiologist to do a complete and thorough study. There are many factors that can explain a change on the mammogram when compared to the previous study. These include weight gain, weight loss, hormone replacement therapy, menopause, other benign diseases, and of course, cancer. It is my job to consider all of these factors when evaluating the study. I want to emphasize again that a mammogram is uncomfortable, but if you do not feel mild to moderate discomfort, your breast was probably not compressed appropriately. The actual mammogram has evolved through research and technology, and we are now diagnosing cancers that are much smaller because of the invention of 3D tomosynthesis. 3D tomosynthesis allows the mammographer to examine your breast tissue one layer at a time. A good analogy for this technology is comparing this to reading a book. We not only see the front and back covers, but we can now see the individual pages. The patient is still imaged only twice on each side. The difference is that the X-ray machine makes a sweeping arc over the breast, and this gives the mammographer 1 millimeter slices to evaluate. So as the patient, you will not know the difference between a digital mammogram and a 3D tomosynthesis mammogram. It's just that the 3D tomosynthesis study gives many more images to the radiologist. This invention has been invaluable, especially when imaging dense breasts. I can diagnose cancers as small as 1/5 of an inch. I would like to briefly address the arguments that I hear against annual screening mammograms. Clearly, only 12 of 100 women that I see will develop a breast cancer. Obviously, the majority, or 88 of the 100, will not develop breast cancer. And then, of course, there are the women with a change on the mammogram or an abnormal mammogram that go on to get a biopsy. And again, most of these women will have benign disease, not cancer. But my question to you is, the risk of having a biopsy that some people may say is quote unquote unnecessary because the results are benign cannot outweigh the risks of missing a breast cancer because you did not get your mammogram. The best preventive technique for breast cancer we have today is annual mammographic screening. Mammograms are a critical element of our management and control of this disease. What other imaging modalities do we have to help diagnose breast cancer? The mammogram is the first line of defense and the standard non-invasive diagnostic and screening method. Mammography is the only imaging modality proven to reduce mortality from breast cancer. If there is a questionable finding on the mammogram that needs further evaluation, the radiologist will recommend one of 2 additional studies, a breast ultrasound or an MRI. Breast ultrasound is a procedure used to further evaluate an abnormality seen on the mammogram. This imaging technique uses sound waves, not X-rays, so there is no radiation exposure. The primary function of a breast ultrasound is to determine if a breast lump is fluid-filled or solid. Fluid-filled masses are called cysts. They are not cancer, and they are generally of no concern. They do not turn into breast cancer, and they do not increase your risk of breast cancer. Solid masses, on the other hand, have to be biopsied because they can be cancer. The ultrasound study is pain-free and usually done by an ultrasound technician. In my office, I do the breast ultrasounds. I will not let an ultrasound technician do the breast ultrasound. Again, you will undress from the waist up. You will be given a sterile gown that opens up in the front. The study is done while you lie on your back. The technician controls a small handheld device that she will move over your breast. As she moves the device, she can see the breast tissue on the screen. If there is an abnormality, she will call the radiologist in to evaluate the area of concern. The ultrasound study can take up to 30 minutes, especially if there is some confusion between the clinical history, what was seen on the mammogram, and what the patient is actually worried about. I get asked every day if an ultrasound study can be done instead of a mammogram. The answer is no, absolutely not. There are so many abnormal findings that cannot be picked up with ultrasound. They can only be identified on the mammogram. Magnetic resonance imaging, also known as MRI, is one of our newer imaging modalities. It is used as an adjunct to screening mammography for women with an elevated lifetime risk of breast cancer. This group includes women with very dense breasts, women who are BRCA1 or BRCA2 mutation carriers, women with a personal history of breast cancer, and women who have multiple first-degree relatives with breast cancer. MRI scans are usually done in an outpatient setting in a hospital. You will have an IV line placed in your vein in your arm so that the contrast agent can be injected. This contrast agent is gadolinium. This agent is crucial because it's what helps us identify abnormalities in the breast. You will lie down on a long table with your arms over your head. Your breasts will hang through small openings in the table. The table slowly slides into a long, narrow tube. This is called the magnet. The machine may make a loud thumping or clicking noise. You need to lie still for the duration of the exam. Some require sedation to complete the study. This exam can take up to 45 minutes. I find this the most difficult of the breast imaging studies because you are in a difficult position on your stomach, and the machine makes a loud thumping noise. Plus, you may feel trapped within the tube. If you are claustrophobic or the prone position is difficult for you, sedation may be considered. I find it necessary as a breast imager to briefly discuss thermography. Thermography measures temperature differences in the breast. The temperature is a reflection of blood flow. This study, in my opinion, should never replace the modalities I have discussed above. It is not specific, and a thermogram will never clear your breast of a malignancy. So to briefly simplify the steps for diagnosing breast cancer, you start with a mammogram. If additional views are needed, they will be done either at the time of the mammogram or shortly thereafter. If there is a need to further evaluate a lump, a breast ultrasound is the next step. MRI is the last study done, and this is only for a small subset of the population. Let's talk briefly about the treatment of malignant breast tumors. I will only discuss this topic because everyone's breast cancer is different. Because of your genetic makeup, the size of the tumor, the cell type of the tumor, the node involvement, and the receptors of the tumor, your treatment will be different from everyone else. You may need a lumpectomy, which is just removing a small amount of tissue, a mastectomy, which is removing the breast, follow-up radiation, chemotherapy, and/or hormonal therapy. You will have a team of specialists that you should choose. A surgeon will perform the lumpectomy or mastectomy. A radiation oncologist will perform the radiation. An oncologist will give you chemotherapy specifically designed to treat your type of cancer. And lastly, if you choose breast reconstruction, you will also have a plastic surgeon on your team. I cannot stress strongly enough that there are specialists in all of the above fields, and you need to do your homework and find the best team for you. I encourage you to get second opinions. Meet with your team of physicians and ask questions. But please remember that your cancer is unique to you, and the recommended treatment may not be, quote unquote, what your friend had. But how lucky are we today, because of years of research, that breast cancer treatment can be tailored to each and every individual patient. So in closing, I beg each and every one of you to help me help you. I cannot diagnose a breast cancer without a mammogram. I cannot diagnose a breast cancer at its earliest, most curable stage if you skip several years. If you sense any change in either breast, please call your clinician. Please call me. My contact information is listed on my website. A negative mammogram does not guarantee freedom from breast cancer. The final thought I want to leave you with is one that no one thinks about. Do you know who reads your mammogram? Is that radiologist a specialist in breast imaging? Studies have shown that when reviewing a mammogram that were read by radiologists who had only basic training in breast imaging, 25% of the cancers that were eventually diagnosed were evident on earlier mammograms and should have been picked up at least 1 year earlier. You are all educated women, obviously proactive when it comes to your health. So besides getting your annual mammograms, doing breast self-exams, I beg you to ask yourself, who is my mammographer? Thank you, everybody, for listening. And if you have any questions, please look at my website and send me some emails. Thank you.
Hi, everybody. This is Alexandra again. I just want to thank Kim for her wonderful, wonderful presentation. We cannot thank her enough for agreeing to do this webinar with us and sharing all of her knowledge with us. As Sassy mentioned, it's crucial for a patient and provider to be on the same wavelength and to be in understanding communication with one another. And Kim is a perfect example of a physician who is leading the charge in that direction. Thank you, Kim, again for being here and speaking with us, and also just for everything that you do in the breast cancer world and for all of your patients, and for just being here and sharing all of that with us today. Kim's contact information for her breast cancer center, including their phone number, their email, and just how to get in contact with them, that will be on our follow-up email, and it will also be on our website. Okay, so next I am thrilled to introduce a really great individual who is also doing wonderful things in the breast cancer community. Natalie Lynch is the Senior Development Manager with the American Cancer Society right here in the greater Philadelphia area. She graduated from Penn State University, and she also works with the American Cancer Society's Relay for Life program, as well as their Making Strides Against Breast Cancer movements. So she's good here. She's going to tell us a little bit about the American Cancer Society and all of the things that they do, as well as some of their available resources for us. So without further ado, Natalie, if you're here.
Thank you so much, Alex.
Of course.
Hi, everyone. As Alex said, my name is Natalie, and I am here with the American Cancer Society. I'm really excited to be able to talk to you a little bit about what the American Cancer Society does, but more importantly, give you some resources that we have available to the public. So first, just a little background on ACS. Our mission is to save lives, celebrate lives, and lead the fight for a world without cancer. We are currently the largest nonprofit funder of cancer research, and we really focus on attacking cancer from every angle. So some of the ways we do that are by promoting healthy lifestyles. We offer cancer prevention steps. We provide support through our hotline. We help fight for policy change by working with lawmakers through our advocacy affiliate, ACS CAN. We fund and conduct life-saving research. We address cancer disparities, and we really take action alongside our 1.5 million volunteers who want to make a difference. And tying more into the topic today of breast cancer, one of our big movements is Making Strides Against Breast Cancer. And this is the largest network of breast cancer events across the nation. And they kind of take place or vary in the way that they take place, whether it's a large scale traditional walk or a unique local experience and celebration. But all of our Making Strides events have some things in common, including the fact that their purpose is really to unite communities, companies, and individuals across the country to help in the fight to end breast cancer. And we've been hosting these events for over 2 decades, and the funds that we raise through the events are all put towards the American Cancer Society to help serve patients and their families where and when they need us the most. So that's just a little background on the American Cancer Society. The bulk of what I'm here to talk to you about today is some of the resources that we offer at ACS. And we really focus on being inclusive and offering a wide variety of easily accessible resources. It is part of our ongoing commitment to meet the needs of all of our constituents, including those with disabilities. So the American Cancer Society is dedicated to constantly improving our accessibility to these resources. The first resource that I'm going to mention today is our National Cancer Information Center hotline. This number is 1-800-227-2345, and this is staffed by trained cancer information specialists. They are available 24/7, 365 days a year. And they are there for really anything you need. They answer questions, they provide emotional support, they help connect patients and caregivers and family members with valuable services and resources. And we actually just celebrated our 25th anniversary of this hotline last month. And since inception, there have been over 25 million contacts to this hotline. So truly some immeasurable impact we've been able to make through this hotline. And again, it's there for anything you may need regarding American Cancer Society or any type of cancer questions, concerns. So the next resource I have to mention is cancer.org. And this is our website that hosts a plethora of different information. Some of that includes cancer statistics and news. There's information about every type of cancer you could imagine. There are tips and tricks on staying healthy. There's information on support options and different ways to get involved in the ACS community. And a couple things I did want to note about our website is that it is compatible with screen readers. We also have a list of publications on the website that are available free of charge to the public in Braille. You just need to go in and request them to be sent to you. We also have all publications on our website available in audio CD, or if you call our 1-800 number, depending on the publication length, those publications can be read to you over the phone by one of our specialists. And we receive over 100 million visits each year to this website. So tons of awesome information for everyone to access here in multiple different ways to access. The next program that I want to mention to you guys today is our Road to Recovery program. This is a volunteer program that provides free rides to treatment for people with cancer who either do not have a ride or are unable to drive themselves. We have been able to provide more than 5.9 million free rides to treatment since this program began in 2005. And I do want to mention that safety is a top priority for this program. So since our drivers are volunteers, we make sure that they have a good driving record, a valid driver's license and insurance, and they must go through ACS training. So really focused on making sure that our volunteers and our patients are safe through this program. And one more thing to note about this program is we are in the process of getting it up and running again due to COVID-19 and all of those restrictions. So it's in the process of getting back up and ramping back up to those pre-COVID times and being fully accessible to everyone who needs it. So if this is a program you are interested in taking advantage of, you can call our 1-800 number to set up an appointment. Just be sure to call well in advance of your treatment appointments, just to make sure there's enough time to get rides coordinated. So the next program I have to mention is specifically for breast cancer patients and breast cancer survivors. It is called our Reach to Recovery program, and this has been in place for over 50 years. And this program really, the purpose is to connect people who are currently facing breast cancer with trained volunteers who are also breast cancer survivors. So essentially how this works is you would go into either the website or the app and you would create a profile. And then within seconds, the program will connect you with a trained volunteer who has also been through breast cancer themselves. And these volunteers are really there to offer understanding and support and offer hope because they themselves have survived breast cancer. So it really just gives patients an opportunity to express feelings, talk about any concerns, and ask questions of someone who has been there. So it's just a level of support that you may not be able to receive from friends or family due to the fact that they themselves have not been through breast cancer and don't fully understand what you're going through. So these volunteers are there for any way that you may need them. And you also get to choose the way to connect with this volunteer. So whether that's through a chat, through a phone call, through a video call, whatever you're most comfortable with, you have the option to do. And one thing to note, I do just want to say that these volunteers are not there to offer medical advice. It's really just for emotional support and having another outlet for these breast cancer patients. Another program that I have to mention today is our Hope Lodge program. And this is essentially a hotel where cancer patients and their caregivers can stay for free when they're receiving out-of-town treatment. We have over 30 Hope Lodge locations across the United States and Puerto Rico. And since we have created these Hope Lodges, we have been able to provide more than 6 million free nights of lodging. And each location, they kind of vary slightly in the accommodation and eligibility requirements, but each location does provide a home-like environment where guests can either retreat to their private rooms or connect with other guests in the common spaces. And there's also always at all the Hope Lodges, there's going to be a variety of resources and information about cancer and how to best fight this disease. And the main purpose of these is so that these guests can focus on getting better. We believe that if patients don't have to focus on or worry about where to stay or how to pay for lodging, it really allows them to focus on getting healthy, which is the main goal of all of this. And the last thing that I wanted to briefly mention to you all today is our local American Cancer Society events. As I mentioned briefly, there is a page on our website that lists all the events in your area. So you're able to go in and kind of filter out events based on either the type of event you're looking to participate in, or you can enter your zip code and it will narrow down the events in your area by like geographical vicinity. But if you're not familiar with ACS events, we have a ton of different types of events, including our Making Strides events, our Relay for Life events. We have runs, we have bike-a-thons, we have galas. So tons of awesome events that most likely you have some sort of event that takes place in your community. We host thousands of events each year across the United States. So whether you're looking to get involved as a participant, as a volunteer, as a sponsor or donor, there are so many ways to get involved. And it's just another great resource that allows you to connect with other survivors, other caregivers, and just community members in general that are looking to make a difference. These events are such a positive and uplifting environment full of inspiring individuals. So it's a great resource if you're looking to get more involved in in-person events in your area. So those are all of the resources I have for you today. I hope one of them sticks with you. And if you know anyone that could benefit from these resources, please feel free to pass them along to anyone who might benefit. I will give my email and such to Alex after this. So feel free to email me if you have any questions about any of the programs that I mentioned today. But also, when in doubt, just call that 1-800 number. They will be able to connect you with the correct contact. So thank you all today for letting me be here to speak, and you all listening to some of the resources and some of the things that we do here at American Cancer Society. So thank you so much.
Oh, there we go. Thank you so much, Natalie. This is Alexandra again. As I mentioned before, Natalie is just wonderful. She's been wonderful as we were planning this webinar. So I just want to thank her a million times for just coming and speaking about all of the resources that the American Cancer Society has, and just coming and letting us know about them. So once again, thank you, Natalie, for what you personally do for the American Cancer Society and also for the strides that the American Cancer Society is making as well. Next, I would like to bring in Joan Yeager, who is the Chief Marketing Officer with Hadley. We're so pleased to have Joan with us today to introduce our next presenter. So please, Joan,
Thank
take it
you.
away. Of course.
Thank you. And thank you so much for the opportunity to chat with you today on this, very important educational talk. I've gotten a lot out of it just listening along. And I hope those, I can share a few minutes about the wonderful nonprofit that I work for. I'm going to share my screen. Now, it looks like I need to be able to share my screen. It says it's disabled. I'm not sure why.
Let me try to give you allow. Oh, there you go.
There we go.
Awesome.
Thanks again. So as I said, I work for an organization called Hadley, and we are a nonprofit located in just north of Chicago. And I'd like to think of Hadley as a 100-year-old startup. We are dedicated to helping those with visual impairments, and we've been doing so for 100 years. However, let me explain a little bit about the combination of 100 years old and yet still a startup. It all started with this gentleman I'm showing on the screen now. His name is William Hadley. And it was 100 years ago, just 100 years ago last year. He was a school teacher in Chicago. He lost his sight as a complication from the flu pandemic of 100 years ago. And one of the things that most challenged him was the printed pages of his extensive library no longer being useful to him. He fell into a depression for a while there, and then decided that he could find another way to continue to read and enjoy life again. And he basically taught himself Braille, and therefore then was able to do one of the things he most enjoyed in life. And when he mastered that for himself, he decided to combine his skill at teaching with his newfound skill at Braille, and reached out to other adults with vision loss, knowing that others were likely in the same boat as he had been prior to learning Braille. And so he started teaching again. And his first student was a woman in Kansas who, like him, had lost her sight later in life. And Hadley sent her lessons in the mail. It was kind of a correspondence way of learning Braille. And the Hadley organization was born. As I said, that was the year 1920. At the time, this correspondence way of teaching Braille was revolutionary. And as you can see, I'm showing a print ad from way back in the day. And it shows William Hadley, as well as a couple of his students, and a mailman getting mail from the building here. And the headline is Hadley's doing the impossible, but Hadley did do it, and quite successfully. And we've taught Braille to more folks worldwide than anywhere else. And in fact, back in the day, we were known as Braille by mail. Fast forward 100 years, and you can see a modern foyer of Hadley today. This is Hadley. In July 2020, our centennial year, we relaunched Hadley with a strong focus on using today's technology to reach and teach those with vision loss, to help them thrive. And of course, what that means to thrive will look differently depending on the person. We have a virtual reality room that we use to give local medical professionals and those studying to become medical professionals a small glimpse into some of the challenges their patients may be facing, doing everyday things like here I'm showing our room with folks trying to cross the street without having much vision. We also relaunched our website to make it seamless for folks to learn what they want to learn. Daily living tasks like cooking or medication management, social emotional support associated with adjusting to vision loss, recreational topics like gardening or adapting card or board games, Braille, of course, our founding topic, working how to adapt Outlook, for instance, to better meet your vision needs. and technology, because there's one thing to say, we have all sorts of modern tech tools that could help those with vision loss today, but quite another to know how to use them to best effect. And each workshop we offer at Hadley is short, focused, and filled with practical tips that you can put right into practice. For instance, putting one bump dot on the top of a blood pressure med you take once a day, and 2 on the top of arthritis meds you might take twice a day. Our tech tutorials break things down into simple step-by-step instructions and can be listened as often as someone wants to. One of the comments I love to read, it sounds something like this. It felt like Doug was sitting right down next to me. He didn't rush or assume I knew all those tech terms. I just felt good listening to him and learning with him. Importantly, each workshop at Hadley is staffed by vision professionals. So while much of what we have is online, no question should go unanswered, and Hadley's individualized help is just an email or a call away. We also host a monthly discussion groups on 10 different topics. These call-in groups range from gardening to crafting to our most popular one, technology. It's really important to us at Hadley that all of our learners have the opportunity to ask their own questions, hear from our own experts, and importantly, learn and hear from each other. What we found is these groups are invaluable for many. It replaces a sense of isolation and loneliness some feel if they've acquired vision loss later in life, to a community of others who really get it. And while we love our new online platform, we realize that not everyone feels comfortable online. You know, and in fact, you might be learning how to better use your computer now that your vision is faded, and may be difficult to learn on your computer. So Hadley also sends out large print, braille, and audio tracks to folks all over the world. And last but not least, Hadley's free. There are no doctor's notes needed, no waiting lists, no trips to our office required, and absolutely no bills to pay. Really, with just one simple sign up, all of Hadley is there at your fingertips. So I invite you to check out Hadley's Help for yourself. You'll find us at hadley.edu. And at this point, I'd like to introduce the next speaker. So it's my honor to introduce Dr. Jill Likon. Dr. Likon is the clinical hematology oncology pharmacy coordinator at the University of Miami Hospital and Clinics. She received her Doctor of Pharmacy from Temple University in Philadelphia, and her daily work involves developing treatment plans for oncology patients, managing chemotherapy, immunotherapy toxicities, and working with patients and their families around expectations of cancer treatments. So with that, I'll leave it over to Dr. Likon.
Thank you, Joan, so much for the introduction. So again, today I wanted to talk about some of the cancer treatments that we have for breast cancer. As you guys know, globally, breast cancer is the most frequently diagnosed cancer for women and the leading cause of death for cancer-related death for women in the United States. Breast cancer can be treated though in several different ways. Really, the treatment for breast cancer does depend on the cancer itself, as well as how far it's spread. People with breast cancer often get more than one kind of treatment. We call this often in the oncology world a multimodal approach. Often, surgery, chemotherapy, and radiation is the backbone of treatment. Chemo that you typically think about, which is very toxic and can lower blood counts and require platelet and red blood cell transfusions, is not the same as it used to be. Recently, we have had newer advancements in our chemotherapy products, and I'm kind of going to talk about that a bit today, and how these new advancements are able to treat different types of breast cancer. Like advancements we have seen in our iPhones over the past couple of years, if we think back to the first iPhone and the iPhones that are out today, we've also seen the same type of advancements in chemotherapy. Historically, chemotherapy has always been non-specific and targets rapidly dividing cells. These chemotherapy medications can work on our normal cells, such as our hair follicles or our gut mucosal lining, Or chemotherapy can target what they're supposed to be targeting, and that's the cancer cells. Recently, advancements have been in chemotherapy has created those drugs that we give to target the breast cancer cells more specifically. Today, we have smarter chemotherapy. We also have genetic testing that's also an integral part into the breast cancer management. Although most breast cancers are sporadic, meaning they occur randomly, there is a mutation called a BRCA mutation, which today we have drugs such as olaparib or talazoparib that can target this mutation. I do want to stress, though, that unfortunately the BRCA mutation only accounts for a small percent of breast cancers, and so these drugs do not apply to everyone. The National Comprehensive Cancer Center Network, also known as the NCCN, and the American College of Medical Genetics and Genomics have extensive guidelines which reviews the criteria for women to be considered for germline mutation testing. Additionally, tumor cells, aside from our genetics, can tell us a lot about the type of cancer that a patient has. We can categorize the cancer cells into specific subtypes, and we have specific chemotherapies that can target those subtypes. One of the most notable subtypes of breast cancer therapy is those patients that have HER2 positive breast cancer. We also look at estrogen or progesterone positive breast cancer. In the absence of either one of those receptor positivities, we have triple negative breast cancer. To begin our discussion of the advancements of chemotherapy, those patients presenting with HER2 positive breast cancer, which usually is an overproduction of a specific protein on the outside of the breast cancer cells. We've developed monoclonal antibodies, which are specific proteins in the form of chemotherapy that target these tumor cells on the breast cancer cells. Recent advancements in chemotherapy have exploded our arsenal to target HER2. Initially, when HER2 was developed and drugs were used to target this receptor, there was only one drug available on market for that. Now we have up to 5 drugs that target HER2. For breast cancer tumors that do not express HER2 and they express estrogen positive or progesterone positive breast cancer, we can use estrogen decreasing therapy. Typically, this therapy can go on for 5 to 10 years. What's important is that these medications can have side effects. Any medication that has a side effect or any medication that's prescribed by a breast cancer doctor should always be, the patient should always discuss with the provider or their healthcare team any side effects that they're having and should not abruptly discontinue the medication without talking to the provider. For patients in the metastatic setting, we have newer drugs that target CDK4 and 6. These drugs, such as abemaciclib, palbociclib, and ribociclib, can be used in combination with estrogen decreasing therapy, such as fulvestrant. This combination has recently showed improvement in overall survival for breast cancer patients compared to those taking estrogen decreasing medications alone. So again, we're doing a lot of clinical trials in order to advance breast cancer therapy. In patients neither expressing estrogen receptor or progesterone receptor or HER2, these we consider triple negative breast cancer and traditionally are treated with standard chemotherapy. What's great though, in the last year, we actually had a newer monoclonal antibody that was been approved to treat triple negative breast cancer. Again, advancing therapy in one of our harder subtypes of breast cancer to treat, which is really great for all of our patients. And so lastly, as a pharmacist working in this unique cancer patient population, I want to stress and talk about some supportive care, because I wouldn't be a pharmacist if I didn't address the supportive care needs of our patients who are getting breast cancer treatment. And so if I took a poll right now of the room, I would bet most of you associate chemotherapy with nausea and vomiting. And so nowadays we have newer drugs that treat nausea and vomiting or prevent nausea and vomiting. Some of those include palonosetron or fosaprepitant, 2 drugs that are very strong and help with decreasing the amount of nausea in patients. I always tell my patients when I'm rounding down them, If you're vomiting or you're nauseous, that means I'm not doing my job right, because I know that there are medications out there that can help prevent any nausea and vomiting. The advancements that we have made in chemotherapy are mostly due to clinical trials. As a pharmacist that works in an NCI designated cancer center, I have seen firsthand how clinical trials have advanced our treatment for breast cancer and have led to better outcomes for our patients. Enrolling in clinical trials should always be done at a cancer center that has appropriate clinical trials. You should not be going off and doing them on your own, as they can be dangerous. Clinical trials here at UM have increased our patient populations, especially in the breast cancer realm, and have brought more patients to our center who are looking for these clinical trials. I would like to thank Accessible Pharmacy Services for the Blind for inviting me here today to talk to all of you. I would like to thank my patients and their family members, my teams of doctors and nurses, and all the support staff who help make the goal of curing cancer possible.
Thank you, Jill. Sorry, I was worrying about the spotlight of the videos and things like that. We are so thankful for Jill, and I just cannot say thank you enough. We're just so grateful that you were able to speak with us today. What you do on a clinician level, but also on a patient level, is so important. So I just want to extend a huge thank you from the Accessible Pharmacy team, and I assume from all of our attendees here at the webinar for taking the time to give us such a thoughtful presentation. Before I bring in our next individual, I just want to make a few quick announcements. As I mentioned earlier, right before the webinar started, all attendees will receive a follow-up email early next week. So this follow-up email will have a few things in it. First, we're going to break down the webinar by presentation. So each presentation will have its own video and audio clip on our YouTube page, and then also on our website. So you will each have access to those recordings. The website, or excuse me, our website will also have the audio description as well as a text version of the breast self-exam, which was narrated by Dr. Kubek in the beginning of the webinar. As Natalie mentioned earlier, the American Cancer Society provides brochures of different breast cancer topics in Braille. We here at Accessible Pharmacy, we have a few copies of each topic available. We can mail a copy to you free of charge. You just need to call us and ask if we have it for you. So like I said, we only have limited availability, so just be aware of that when you give us a call. Also, when you get this follow-up email, please go ahead and respond to it and let us know your feedback on the accessibility of this webinar. We would love to know how to make it more accessible for you, and how we can continue to make programs like this in the future. So please respond to it, let us know your feedback. And like I said before, if you are attending this webinar as a healthcare professional and you are able to earn continuing education credit for being here and participating, this webinar is certified by the CRCC, so the Commission for Rehabilitation Counselors. So if you're able to get your CE credit certified through them, please either email us or respond to that follow-up email that you'll get at the beginning of next week, and we'll get that handled for you. We are also excited to announce our next health webinar. So coming later this spring, we'll be having a webinar for parents who are blind, and we will also have a webinar on eye drops. So we'll have some more information on those coming out soon. I'm also excited to announce that coming this summer, we will be launching accessible telehealth. So in which our patients will be able to telehealth with our providers. It will focus on behavioral health and mental health with people with disabilities. And our goal is to create the most accessible and welcoming telehealth model for people with all disabilities. Okay, just a couple quick more announcements. We are expanding our labeling solutions. So if you're not familiar with us here at Accessible Pharmacy, we do provide accessible packaging and labeling options for you to manage your medication. We are in the process of buying a new large font printer, so we'll be able to label in larger font than we're already labeling in. And then we've also upgraded our Braille capabilities as well. So we are able to label in grade 1 as well as contracted Braille labels. If you don't know already, we do work very closely with ScriptTalk. So ScriptTalk is a talking label solution. If you are in the market for a talking label, please just give us a call and we can talk about if this would be a good solution for you. But based on huge feedback from our patients, we've actually added some additional audio label options. We've continued our collaborations with OrCam and also with WayAround. So we are in the process of integrating our stuff into OrCam. OrCam is essentially computerized vision. If you are an owner and a user of an OrCam device, you will soon be able to use an OrCam device to also manage your medication with Accessible Pharmacy. And then also we are integrating with WayAround. So WayAround is a company that produces stickers called WayTag stickers, and they are read aloud by an app on your smartphone. So WayAround will soon be another labeling option here at Accessible Pharmacy. So if you're a user of WayAround, you'll soon be able to also label your medication from Accessible Pharmacy with WayTag stickers and have that medication read aloud by the WayAround app on your smartphone. Super exciting stuff, and we're thrilled about it. Lastly, we have just gotten approved to support patients in South Carolina as well as Kentucky. So if you reside in either of those states or support individuals in either of those states, please just give us a call and we can bring you on as a patient here at Accessible Pharmacy today. So these states just add on to the many other states that we are licensed in. So if you're wondering if we're already licensed in your state, just give us a call and find out. Okay, now I'm done and we can move on to our last presenter, which I'm super excited to hear from. But first, I'm excited to virtually bring in Lori Scharf from the American Council of the Blind to introduce her. And Lori is with the American Council of the Blind Women's Committee. So Lori, if you're here.
Thank you, Alex.
Of course.
So the American Council of the Blind Women's Committee works on issues impacting blind and visually impaired women across the country. And we hold monthly what we call community meetings, and those topics vary from month to month. Additionally, we hold programming in conjunction with the American Council of the Blind National Convention. What I'm here to talk about today is our program that started in 2008, which is a breast cancer peer support group. And this peer support group is facilitated by myself and Linda Perel, who are social workers. We also both are blind. And this group is exclusively for people who are blind or visually impaired and have an actual diagnosis of breast cancer. And we've been going since 2008. We meet monthly through Zoom and for about an hour to an hour and a half, depending on, you know, what's going on for the different women. And whenever there's no specific, you know, time when you can come and can't come into the group. So when we have new participants joining the group, we kind of do a little rundown of who everybody is and what their diagnosis is and where they are in their process. So it's a very close-knit group, and we have great resources and peer support. So if anybody is interested in joining, you can get in touch with me through the information that will be available in the email that Alex spoke about. And our next upcoming meeting will be this Tuesday at 8 p.m. Eastern, and it's the first Tuesday of every month, and we don't meet in July. It now is my honor to introduce Kristen Capizzi. She is a graduate of the Philadelphia College of Pharmacy at the University of Sciences, and she specializes in working with people who have complex health issues, as well as individuals who take multiple medications. Dr. Capizzi is a board certified geriatric pharmacist. I didn't even know that was a specialty. So when I saw that, I said, wow. And her reason for being here today with us is that she is the director of women's health at Accessible Pharmacy. Doctor, thank you very much.
Thank you so much for that introduction. Again, I'm Dr. Kristen Capisi, and today I wanted to discuss a little bit about systemic therapy, specifically hormonal therapy. So we just heard from Dr. Lycan, who spoke a little bit about estrogen reducing medications, and I'm kind of going to jump off of that point and go a little bit further into some of those medications. So what is hormonal therapy for patients with breast cancer? Basically, there's 2 out of 3 breast cancers that are hormone receptor positive, which means that they are positive for either estrogen or progesterone receptors. These tumors are utilizing these hormones to grow and divide these cells to further enlarge the malignancies. So the endocrine therapy, which is what hormonal therapy is going to block the usage of these hormones in order to block the growth. This is going to prevent the recurrence of cancer either distantly or in the same breast or opposing breast, as well as reduce the risk of recurrence. So there's 2 main types of hormonal therapy that I would like to discuss today. I'm just going to briefly go over their place in treatment, how they work, and some of the more significant side effects or drug interactions. So these 2 types of therapy that I'm going to speak about are the selective estrogen receptor modulators, as well as aromatase inhibitors. So first, I'd like to speak about those selective estrogen receptor modulators, and that is a mouthful. So exactly what does that mean? These drugs actually block the estrogen from binding to breast cancer cells, effectively inhibiting that growth and division of the cells. Selective estrogen receptor modulators are able to prevent recurrence about 50% of the patients that use them. And the most commonly used medication from this class is tamoxifen. So some of the side effects that, of course, do come along with these medications include menopausal-like symptoms. So things like hot flashes, vaginal dryness or bleeding, things of that nature in which, there's fatigue, mood stabilization, and the selective estrogen receptor modulators are typically used in premenopausal women. This class of drugs can be used in both pre and postmenopausal women, with the option of premenopausal women also combining with ovarian ablation or, excuse me. I'm so sorry. I apologize. Selective estrogen receptor modulators are going to be able to work with premenopausal women with combination, not necessary, but with combination of ovarian ablation or medications that suppress the action of the ovaries, creating estrogen. The other type of medications I wanted to discuss today are aromatase inhibitors. So how do aromatase inhibitors work? The aromatase enzyme is actually what converts the weak male hormone androgen into estrogen once women are postmenopausal, so their ovaries are no longer producing estrogen. The aromatase inhibitors actually block this conversion, which is going to decrease the amount of estrogen that's made in tissues other than the ovaries. So aromatase inhibitors are the most beneficial class of drugs to use for postmenopausal women. However, there is the option of using these in premenopausal women if they do decide to combine therapy with either ovarian ablation or ovarian suppression. Some of the common side effects of aromatase inhibitors include musculoskeletal pain as well as arthralgias. They do have some of the menopausal symptoms as the selective estrogen receptor modulators do. However, the more common ones are the skeletal pain as well as arthralgia. Aromatase inhibitors are commonly used either after tamoxifen therapy, or if they are used in postmenopausal women, they can be used as initial therapy. So some treatment guidelines in terms of treatment of hormonal therapy for women who have breast cancer. Premenopausal women and postmenopausal women are treated differently. So to start with premenopausal women, typically tamoxifen is the standard for premenopausal women. They generally use tamoxifen for 5 years. And then at this point, there is some consideration as to whether, one, there's still a high risk for recurrence, and two, if the patient is now postmenopausal. So in the event that they are postmenopausal, the patient can at this time switch to an aromatase inhibitor, which has more benefits for postmenopausal women. If they are not postmenopausal at this time, they can do a couple of different things, one of which is to continue tamoxifen therapy for another 5 years. Another is to choose at this time to switch to an aromatase inhibitor, however, combining this with ovarian ablation or ovarian suppression. Those are going to be the two main options for women who are premenopausal. The women who are postmenopausal can start with aromatase inhibitor therapy, and that is typically what is recommended. However, they also have other options. They can start with the tamoxifen like a premenopausal woman, and then utilize tamoxifen for about 5 years. At that time, they can choose to switch to an aromatase inhibitor. Another option for them is to use tamoxifen for a shorter period of time, such as 2 to 4 years, and then to round out that 10-year of therapy with aromatase inhibitors. Again, aromatase inhibitors typically are used in postmenopausal women, and most times they show more benefit when used instead of just simply tamoxifen alone. There are some drug interactions I wanted to highlight just to go back to tamoxifen. Tamoxifen is what is known as a CYP2D6 inhibitor. Basically, that means that it's inhibiting an enzyme that breaks down certain drugs in the body. And I'd highlight this because it affects some of the antidepressants that are used. And in light of situational depression or patients having a concurrent diagnosis of depression, sometimes a little bit of navigation is needed in this area. So women who are CYP2D6 positive can do one of two things. Some are high risk for having an issue with these drugs. And at that time, a provider may want to do further genotype testing to really see where they're at with this. There is also the reasonable alternative to use aromatase inhibitors if the patient is postmenopausal, or simply to continue to use these medications that are in the antidepressant class, such as Paxil, Wellbutrin, and Prozac. If they are going to be used or continued, it's just recommended that the provider monitor carefully for any type of side effects or non-adherence that might prevent the medication from working to the greatest extent that it can. So that was a lot of information that I just threw at you. But those are the two main types of hormonal therapy that I was going to speak about today. However, if there are any further questions, you can use that follow-up email to contact me. But I'd also just like to leave on the note that, and I believe Dr. Lewis, complementary and support the cornerstone of treating. So be honest communication with providers and willingness as a provider to sort of meet the patient where they're at and to work in a partnership is how I believe diseases are most, but a lot of goes a long way in terms of having them feel like you're accommodating and also in their healthcare. So that is all I have to share today. Thank you to be here, and you can
There we go. Thank you, Kristen. You're just fabulous. So thank you, thank you, thank you so much for being here and just sharing all of that with us. We can't thank you enough. What Kristen does is so important. And we're just so thankful to have her. Thank you for coming to speak today. And also just thank you for everything that you do on a daily basis with Accessible Pharmacy. Unfortunately, we are at the end of our webinar. So I would just like to thank all of you for attending on behalf of our team at Accessible Pharmacy. We are so grateful to have such a wonderful turnout. I also want to thank all of our presenters for giving such thoughtful and informative presentations, as well as our introducers for coming on and speaking about all of their organizations and just for being here and for all of the wonderful work that they do. You'll be able to find our presenters' contact information on our follow-up email, as well as on our website. And lastly, a huge thank you to our sign language interpreters, Mel and Emma, for assisting with the accessibility of this webinar. Please check out our follow-up email that will be going out in the next few days. We would love to hear from you. So please, just check that out. And I would also just like to say before we leave, that if you are not a patient of ours here at Accessible Pharmacy, we would love for you to join us. We learn about how to support more patients by listening to our current ones. So we would love your feedback as a patient too. The easiest way to work with us is simply to just call us. Our phone number is 215-799-9900. Just call us at 215-799-9900. Other than that, we would just like to say thank you again for attending our first breast cancer webinar. We were so happy to put it together and have you all attend. And we will be in touch with that follow-up email. And so, have a wonderful weekend. Thank you.